In the world of medicine, where every decision can change lives, your peace of mind is crucial. This is where Pattern steps in. Imagine insurance made simple, fast, and personalized, just for you. With Pattern, you're not just getting disability and life insurance, you're insuring your future and protecting your greatest asset, your income. In the past 10 years, Pattern has transformed the way over 20,000 doctors secure their financial well-being. Discover the simplicity of securing your future at patternlife.com or click the link in the description. What is asynchronous telemedicine? How can it improve patient care? And how can you get into it? Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. On today's episode, we have Dr. Neil Parikh, who's the Chief Medical Officer of 30 Madison, the specialty telemedicine company operating Keeps, Cove, and NERCs. And he's focused on the company's clinical, research, and strategic partnership efforts. Prior to 30 Madison, he was the president of Oscar Medical Group and senior medical director of Oscar Health, leading care delivery, where he oversaw Oscar's clinic and telemedicine operations, complex case management, and clinical concierge services. He's also assistant clinical professor at UCLA, where he's been teaching and practicing since 2014, and he was recently named one of modern healthcare's innovators of 2024. So Dr. Parikh, thank you so much for being on the show.
Bradley, thanks for having me.
So what is 30 Madison? Just give us like the quick overview on what the company's all about.
Yeah, sounds good. So at 30 Madison, we're a family of brands, family of services that provide specialty virtual first care. As you mentioned kind of in the kickoff, our primary brands and services are Keeps, which focuses on men's hair loss, men's sexual health, men's health in general. Cove, which is migraine care, and NERC, where it's sexual, reproductive, and women's health. And the core of what we do is specialty telemedicine across a variety of different chronic conditions.
And when did you join the operation?
I joined about 3 years ago now. And you also mentioned the kickoff, primary role, chief medical officer, where I oversee our clinical research activities, our quality programming, our programming at large in terms of new conditions we go into or how we expand the sets of services that we provide. And then lastly, our enterprise and commercial activity. How is it that 30 Madison can work better with the larger ecosystem? Where are the ways that we can start to work with more traditional payer aspects of the ecosystem, payment aspects of the ecosystem, including, payers and such. So it's a fun role, fun, broad scope.
So how are you determining, so you said hair loss, migraines, and women's reproductive health, right? Those are the three arms of 30 Madison right now, correct?
Correct. Those are our primary sets of services.
So when you're looking at a potential new service, what are you looking for? How do you determine what's something that we can tackle by telemedicine?
It's a great question. And taking a step back, I could totally understand how men's hair loss, migraine, and women's health may seem like very disconnected sets of conditions. The truth is, we do have a very formulaic approach about how and where we expand into. First, it always starts with the patients. Taking the places that we are already operating, listening to our patients, understanding what are their sets of concerns, what are they seeking from us in order to manage more, so that we can ultimately get to a place where we're managing any and all of our patients more holistically. Secondly, it's very much also about understanding, can you manage these sets of conditions virtually? Is telemedicine an appropriate modality? And in our case, we deliver quite a bit of our care actually asynchronously. So without using either video or telephone as the primary modalities of communication back and forth with our patients. We could talk about it a little bit more, but I think you'd be pleasantly surprised how much you can manage asynchronously and how in certain situations it's actually probably a superior way of delivering care.
Oh, no. My patients are able to message me. And so now they don't have to call and wait for a call back. We have a conversation. I mean, is that what you mean by asynchronous? They'll send me a message and a few hours later, I'll send a message back. maybe the following day. If it's a Friday night, maybe Monday, but I'm still able to manage them. I mean, this is not how I manage the vast majority, but still, like, I understand the benefits of the asynchronous communication, because then there's less waiting around for a response. There's less waiting on hold. There's less overhead.
Absolutely right. That's exactly what I was referring to with asynchronous care, the ability to message back and forth with your provider, largely on your time, but to also an extent from a physician's perspective or a clinician's perspective, being able to respond in a manner that makes sense with your schedule. And I think when we think about asynchronous care, we largely focus on the convenience factor, which certainly translates to increased access. The aspect of asynchronous care, which I've been pleasantly learning over the past 3 years in this role, its ability to fill a gap where care is often stigmatized. It's a format that is inherently more neutral. When you're able to message into a provider, you often have the ability to put more time putting your thoughts on paper. So the messages tend to be longer. They tend to be more comprehensive. Your providers equally have time to respond in a more comprehensive manner, quite often with the ability to curbside or consult with a colleague before putting that response in. Not being able to actually see each other, which at first you might think is sort of a detriment to our typical considerations around a therapeutic relationship, actually creates a much more unbiased and neutral setting for both patient and provider. And I think you sometimes see more honest dialogues. You remove some of the implicit bias that we are all trained. Well, many of us are trained and have ongoing training to try to avoid, but it's certainly hard. And
no, some of us were trained to have it. I'm thinking back to board exams where, like, I think there was a hashtag a while ago, bigot your way to success, where, just based on someone's demographic, you'd probably be able to guess what the disease process they were getting at was. So, some of this stuff hopefully isn't much anymore, but was being trained. And so we need to unlearn some of that.
That's absolutely right.
Yeah.
Yeah. You would look at the demographic descriptor in the question, and you could immediately narrow your answer choices or the answer field. You're absolutely right. It's part of our training, and I imagine generations behind us had it more so. And that takes us into a different tangent, but ties all the way back into how research is conducted or is historically conducted in this country, and a lot of the places where bias has been built into the system and the data that we operate off of.
And the asynchronous care, I'm thinking when you ask a patient, what brings you here today? What's your chief complaint? What's going on? And they tell you in a way that is usually in order of severity or urgency and not in chronological order. Whereas if you're doing it asynchronously and they've got to write it down, my guess is, this is not how I don't encounter patients this way for the first time. They're going to write it in a more cohesive way, that it's going to be easier for the physician to understand just what happened rather than, as it kind of spills out in terms of urgency and severity. The communication might end up being even more efficient this way.
Absolutely correct. Patients have more time to construct their thoughts, reorder their thoughts if need be, and are able to do it on their schedule. They're also able to do it as and when symptoms, questions, concerns come up. It's not sitting there and waiting for the next appointment in order to be able to have that conversation. We've been able to actually measure this and study this in different ways. And it's some of the research that we do that I'm actually the most proud of, because we didn't know going into the actual study what the outcome was going to be. I think a lot of times you end up starting to research questions that you might already know the answer to. These two examples weren't that case at all. These were us looking for QI, opportunities for improvement. And one was where we were looking for where there are disparities in both access and outcomes depending on demographics. We know in migraine care, when you go back to the literature, there are often disparate outcomes depending on the demographics, not beyond access, but even once in front of a provider. Do you end up on the same treatment protocols? Do you end up ultimately being on effective treatment protocols? Through our asynchronous migraine platform, we actually proved that there were equitable both access and outcomes, meaning white or BIPOC. we were seeing the same levels of improvement in the migraine score or MIDA score compared to another demographic. And we actually do believe that a lot of that was driven by the format of care that we just described. The second one, which was also very fascinating, was, we were just trying to figure out a objective way of assessing our provider's website manner. Could you actually deliver empathetic care through a largely messaging-based platform? It would actually seem counterintuitive, right?
Yes. That was one of the things I was skeptical about, that I was on the question list, right? The empathetic approach that I saw described on the website. Wait a second. Definitely give me pause. So sorry, go ahead.
It's a reasonable question, and we asked it of ourselves, frankly. And the way we approached that question was we actually went and took what is typically a brick and mortar tool, the Jefferson Empathy Scale, and slightly adapted it to the telemedicine environment, went out and measured empathy, basically asking our patients, based on this otherwise largely validated scale, how empathetic was the care that they were receiving from their provider. And another place, we're very, very pleasantly surprised how highly we scored, and fairly consistently across all the different services that we provided. And I do think it just kind of comes back to this notion that patients, and they say this anecdotally, but I think the studies like this help validate that, will often tell us that they've never been heard the same way as they have this modality of care.
Leading a medical practice is challenging. There can be reimbursement changes, referral slowdowns, staff turnover, or drama. There are obstacles in the way of achieving your goals, or maybe it feels like you've hit a plateau. Who can you turn to for help with the business of managing a medical practice? The Physician Growth Accelerator, a private practice partner that helps you uncover and overcome constraints in your practice. They will check your business vitals, identify the root cause of what's restricting your growth, prescribe what to do about it, and help you achieve it, just like we do with our patients. Imagine your practice, where stress is reduced, profits increase in both patients and staff, and you are happier. They've been making that vision a reality for over a decade. Isn't it time your practice thrived? Discover how at physiciangrowthaccelerator.com. I'm just picturing like a physician getting an email, about to send a reply, and running it through ChatGPT, asking it to add more empathy to the email. No, I mean, listen, it doesn't matter. Like this, if this is how the sausages are getting made, I don't think it matters as long as the patients are feeling that, right? They're feeling like they're heard. I'm not saying that's how you're doing it. That just popped into my head. Something that I could utilize and maybe have from time to time when I'm sending emails or writing birthday cards or something like that. I have to like add a little flavor to it because it just all ends up sounding so like rote and mundane. So it just seems to me like this, there are tools out there that can help us with this.
100%. And I'm smiling because I think we all know the implications of, actually, maybe the better answer is we have no idea yet all the implications of what AI and ChatGPT represent. But I do think we have identified some areas where, like you described right now, we should already be looking at how to use this tooling. And we certainly are. And it's not just empathy is a big part of it. It's maybe the best encompassing term. But it's ultimately, how do you get on the same level as your patients such that your communication is effective, that you can establish that therapeutic relationship. Ultimately, the messaging lands and you get to a place where both sides feel strongly or good about the shared decision making. And anything that we can do to increase cultural competence, to understand health literacy, to, again, meet patients where they are, which is so much more than just using the same language. We should all be taking advantage of that tooling. And the asynchronous format probably lends itself more easily to integrating those kind of things.
Having my Google glasses giving me like a little script for how to respond to my patient. It's not going to come off as genuine. I know that my listeners are going to want to hear the answer to this. So it's a little bit of a pivot, but I'm sure some of them are chomping at the bit for this particular question, which is, when you are looking for physicians to join 30 Madison, because, we're all looking for different revenue streams than just traditional patient care, right? How do you find physicians and what do you look for in a physician?
Great question. So in terms of, why don't we start with what we're looking for and then how do we find them? Much of the landscape has definitely changed since COVID, and general familiarity with telemedicine, all that you can achieve via telemedicine, and how to integrate that into your practice. Before COVID, and I was in the telemedicine world before that, it was hard. It was hard to find providers that were comfortable delivering that type of care. It definitely, for some folks, I think they felt like they were living on the edge a little bit. COVID changed that dynamic quite dramatically, and most people had to experience delivering care in a telemedicine format. Most people subsequently figured out how to integrate that within their practice. Maybe most is being generous, but many figured out how to integrate it into their practice. In some respect, the payer ecosystem started to also figure out a little bit, it's not perfect, but a little bit on how to both value and reimburse those set of services. So I think from a comfort and a general set of and prior experience, the pool is much, much larger now than what it was before. How do you differentiate yourself amongst that pool? In a handful of ways. First and foremost, as we mentioned, we spent a lot of time talking about asynchronous care. There has to be that openness and availability to actually delivering 99.9% of your care in that format. That's not for everyone. People also self-select out from delivering care in that kind of way. There are others that really do enjoy it and embrace it because of all the reasons that we described, being able to work a little bit more on their schedule and the ability to be more thoughtful and collaborative in your responses. So we do want to get a sense of people's, level of proficiency in delivering care in that way. We certainly also look for experience in the sets of specialties that we operate. Now, do you need to be a specialist? No. In fact, the big part of what we are trying to do is find ways to democratize specialty care. So most of our provider base are family medicine, internal medicine trained, some ER, and others that, for example, neurologists within our headache programming, that will then undergo subsequent training with our medical directors and internal curriculum to develop that extra level of proficiency and expertise. But having backgrounds in the cases and conditions that we manage is a huge bonus. The last thing that I would say, and I think this is pretty universal in the telemedicine space, is while a lot has evolved from a regulatory perspective, there are still major points of friction, one of which is licensing. I think it's worth, I encourage this to many colleagues that are looking at how do you kind of branch out, starting to broaden your licensure, go through the paperwork process, add a few more states if possible. And that makes you just that much more marketable to companies like ours that are operating across the country and subsequently need the right level of staffing and coverage in order to hit our SLAs.
Got it. So you're not saying you'll take someone with telehealth experience locally who then has to dive into the world of, across the United States. You're really looking for people that are already in this similar space in some way and that they have licenses in multiple states. So it wouldn't be, a far reach to, keep adding to that.
I think it sets you apart. The opposite is also true, right? In markets where there are not that many licensed providers, if that's where you are coming from, that is an added bonus for sure. Okay. But no, multiple licenses, it just makes it easier to see more patients, to cover more colleagues, to help us meet all of our coverage requirements.
How are you determining if either you have a service line that you're going to phase out or, something that you're looking at similarly and decide that you're not going to move forward with it, right? What are you looking for in things that don't work with this model?
It's a great question, and it's multidimensional. I think the first and foremost part is if you do not believe you can deliver high quality care through a largely virtual model, that is criteria number one for why we would never even enter or entertain certain service lines. And I think we've all been, pleasantly surprised about how much you can actually manage. So there aren't that many conditions that I think you could totally get screened out using just a pure clinical criteria. I think kind of the nature of the question is a little bit more of a business one on what kind of determines whether something will succeed, and conversely, what have been some of the learnings about where you haven't seen success. I think on the first part, we are certainly looking for condition sets that address a large portion of the population. We are looking for conditions that allow us to manage our patients more holistically, and certainly looking for conditions that there are real access gaps across the country. It's one of the main reasons we've entered places like migraine, or in other areas, even things like HIV prevention and teleprep. The reasons or the lessons learned about where we haven't had success, and there have been some places where we've had to start and stop. Interestingly, some of that is around product market fit. What I mean by that is our aspirations have continuously been to go into more complex chronic conditions. And the truth is, as you start to deal with more complex conditions, those tend to be places where patients are more accustomed to using their medical benefits or insurance to pay for that care, to pay for that set of services. It becomes much, much harder, both from the actual cost and, again, what a patient is accustomed to doing, to try to be a traditional D2C pay all cash for these sets of services. And it was actually some of those lessons that we learned that really ignited our journey into working more within the broader payer ecosystem. We currently have, somewhere between 30 and 50% of commercial coverage, depending on the service that we provide. And within our NERC set of services, the vast majority of the medications we prescribe, you're able to use your pharmacy benefits to cover as well. We think just continuing to chip away and expanding the coverage we have for the set of services that we offer today and the set of services that we want to offer tomorrow are going to mitigate some of those issues that we had where, we felt we had the clinical protocols down, we had the technology there, we know the patients are out there, but the economics around trying to do it pure cash are challenging. And, I think at the end of the day, when it's around that same kind of North Star principle of meeting patients where they are, how do you continue to optimize around meeting their needs? And those needs are more than just clinical needs, right? They've got to be able to afford the care. They've got to be able to figure out ways to be able to pay for the care.
You've used the word holistic a couple of times. When you say holistic about taking care of, migraines or, the other conditions that you treat, what do you mean by that?
So take migraine. It's a great example. In migraine not only is there just general access gaps to headache specialists, but migraine in many ways is still it's an area that there still requires a lot more research and understanding of how to best manage. And while there have been real advances, I think anti-CGRPs in the past few years have certainly given providers like us more tools in the toolkit to help manage patients. The best therapy still tends to be multimodal. And so when we think about managing our patients more holistically, it's more than just an RX. It's more than just a prescription. In migraine, we went and built out our own cognitive behavioral therapy program that was tailored specifically to migraine, which both had self-service modules and coaching layered in. We are believers in non-prescription therapy, whether it be the right types of supplements or devices that can help with pain modulation. Being able to wrap a larger multimodal set of therapies around medications has allowed us to both live up to that holistic ambition, but certainly being able to give patients more options how to manage their condition across what is a journey, not just a single point in time. So that's one version of what a holistic means to us. The second version of holistic is really listening to our patients around what are the other sets of conditions that they would like to see us help them with. Most of our women have come through us through birth control, or they're coming to us seeking contraception. And since then, we've been able to expand into sexually transmitted infections, HPV screening, HIV prevention, mental health, dermatology, all of which came from just truly listening to our patients and the questions that they were asking us.
I love that answer to the holistic question, because I feel like that term has been co-opted by like the wellness industry, and they just use it to sell things that, you know, healing crystals and, you know, Reiki and all this other stuff, that homeopathy. But when you talk about it, you're talking about it like, well, no, we're treating the complete, trying to treat as much of this patient as we can from the telehealth venue as completely as we can, and offer them the evidence-based modalities that are out there. And I love that definition of holistic, because I think we should all be striving to practice that type of holistic care, whatever we're practicing, wherever we are. So thank you for using that definition to help our patients and putting that out there.
No ill will to the wellness folks that are out there, but I hear what you were saying, and there are multiple definitions, clearly.
Well, thank you so much for your time. If people want to find 30 Madison, or they want to find you and connect, where can they find you?
Come to the website. You know, I'm also do my best to respond to anyone who reaches out via LinkedIn, and happy to help any physician, any colleague, any clinician that, you know, is seeking to, looking for ways to expand who they can be and how they can practice.
Well, Dr. Neil Parikh, thank you so much for all you do for patients and in improving access. Neil Parikh, 30 Madison, thank you so much for your time.
Thanks so much, Brad.
Doctors dedicate our lives to caring for others. It's time someone took care of us. Visit patternlife.com to simplify your path to peace of mind. patternlife.com, simplifying your insurance journey. Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it, or like it, or comment on a social media post, or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee, and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice, or financial advice, or really any advice. Thank us again for listening to The Physician's Guide to Doctoring.